Welcome to Fertility Friendly Food. I'm your host, Stefanie Velakis, Accredited Practising Dietitian and Nutritionist and Director of the Dietologist, an Australian-based practice focused on optimising fertility through nutrition. This podcast will bring you snack-size episodes for you to learn, grow and be inspired by the latest research, facts and practical lifestyle tips about eating well for optimal fertility, helping you cut through the confusion and myths to take back some of the control on your fertility journey, one bite at a time. Welcome back, everyone, to another episode of Fertility Friendly Food, the podcast. My name is Stefanie Velakis, and I'm an expert fertility dietitian and nutritionist. And today we have a lovely guest and fellow dietitian colleague, Larissa Telfer, APD. Welcome, Larissa, to the podcast.
Thanks for having me, Steph. I'm really excited to be joining you today.
Yeah, thrilled to be having you. And today's topic is all about diabetes and fertility. So we're going to talk through diabetes for both males and females, type 1 and type 2. And we're also going to be talking about a really popular topic that we both get lots of questions about in our virtual clinics, which is preventing gestational diabetes from preconception. I'm so excited.
Yeah, and I'm really looking forward to touching on that today too.
Yeah, absolutely. So, Larissa, before we get stuck into all the juicy questions, tell us a bit about who you are, what you do, where you're from, so everyone can get to know you a little better.
Great. So, yes, I'm an accredited practising dietitian and also qualified diabetes educator based in Geelong in Victoria. So, I guess, have my foot in a few different areas in that I still work as a clinical dietitian in the areas of diabetes and pregnancy. And then I also have a private practice clinic based here in Geelong and also a virtual online clinic as well. So lots happening.
Yeah, absolutely. And I really love referring my clients with pre-existing diabetes, either type 1 or type 2, to you in their preconception preparation and even in their pregnancy, because I feel like what you do is so amazing in the sense that you can do both the diabetes education as well as the nutrition pieces and fit them all together for somebody. And that saves people appointments, which, you know, you have lots of appointments when you're trying to conceive or pregnant anyway. But when you're trying to conceive or are pregnant with diabetes, there are so many appointments, right? So that really just helps us consolidate.
Absolutely. And having an understanding around some of the diabetes technology and medications and how that all works, as well as being able to piece that together with the food and nutrition side of diabetes is, really great.
Yeah, absolutely. So important. All right. So where did your interest, Larissa, for fertility and pregnancy nutrition and diabetes really stem from? How did you get into this area?
Yeah, so I've been working with, women with diabetes in pregnancy from the start of my career as a dietitian, mostly in the hospital, clinical kind of setting that we talk about. And I was seeing lots of women who have pre-existing, type 1 and type 2 diabetes in pregnancy. And sometimes there's a few particular cases I can think of women that hadn't perhaps planned for the pregnancies, and they were pregnancies that were unplanned, and getting on top of their diabetes then and getting their head around, pregnancy and diabetes, which is a little bit of a hormonal roller coaster in itself without diabetes. I've really just wanted to, try and work with women a little bit earlier, because we know that preconception planning for all women is really important, but particularly for women with diabetes, it's crucial. So as I've transitioned into, more of a private practice setting, I've definitely had more and more women coming through the door who are either planning pregnancy or having fertility struggles that are wanting help with, from a nutrition and a diabetes point of view.
Yeah, amazing. I have really seen a big shift in the last few years in particular around people being really proactive and looking to seek to improve their existing medical conditions or general health and well-being before becoming pregnant. And I think that is just so important and such a testament to some of the work that we do as dietitians and our presence on social media and hopefully positive stories from the media as well. And then I think as well, people just sharing their stories with each other makes all the difference.
Absolutely.
So can you talk to our listeners about the differences between type 1 and type 2 diabetes? Because very often when I ask the question about family history with my clients and they will say, oh, my dad has diabetes, I'll ask type 1 or type 2. And they're not sure, or they're not sure what the difference is, which is pretty understandable. So can you talk us through the differences between type 1 and type 2 diabetes in terms of how they present maybe or how they're treated and what considerations there may be? And then we'll talk about gestational diabetes a little bit later on.
Yeah. So type 1 diabetes is an autoimmune condition. So there's a group of autoimmune conditions. And so what this means is that it's when our immune cells actually attack the insulin-producing cells in the pancreas. So for people with type 1 diabetes, they're no longer producing insulin and are what we call insulin requiring for life. So they require insulin to survive. This is the type of diabetes that I guess traditionally we often talk about, often arises in childhood. So people say, oh, they got it when they're a kid or things like that. But it's really important to know that there is people of all ages are diagnosed with type 1 diabetes. I think that's one of the really common misconceptions, that if people are diagnosed in adulthood that it's going to be type 2 diabetes. And I see time and time again that this is not always the case, and it can certainly be diagnosed even later in life. Type 2 diabetes, I guess, is a little bit different in that it tends to be driven by what we call insulin resistance. So in the early stages, this means that people are still producing insulin, but the insulin's not working as effectively. And what this, I guess, leads to is an overproduction of insulin as it's trying to counteract that insulin resistance. And it's actually progressive, and over time the insulin production actually reduces and to the point of not really producing any more insulin. So the later stages of type 2 diabetes, people will also be requiring insulin, and that's where it can be a little bit confusing. So the terms insulin-dependent diabetes have sort of been, I guess, we've transitioned away from, because we know people with type 1 and type 2 diabetes can be insulin requiring. Yeah.
Oh. Yeah, and it's so fascinating, the differences there. And I think as well, referring back to my episode for those listening, if you're like, what is insulin and what does insulin resistance mean? I do have a whole episode on insulin resistance specifically. So definitely refer back to that. And I guess insulin resistance is just that it's kind of that pre-diabetes, isn't it? It's kind of like that stage of like, hey, your body isn't dealing very well with, the communication between insulin and your cells. It's not coping, time to try and put some lifestyle measures in place to avoid progressing to type 2 diabetes. And then type 1 is that autoimmune disease. And we know any autoimmune disease can trigger at any point in time. Can be in childhood, it can be in adolescent years, it can be in your 20s, 30s, 40s, 50s, it can happen at any age. And I've certainly witnessed that in my experience as a dietitian too. We're seeing lots of late onset, quote unquote, late onset type 1 diabetes. And then everyone goes, oh, it must be type 2, and completely missing the diagnosis entirely, which is incredibly dangerous actually, because there's a completely different management strategies for type 1. As you said, insulin's required to survive, so important. Can we just quickly bust a quick myth, Larissa?
Yeah.
Because I hear so much conversation about, oh, if I eat this or whatever, I'll get diabetes. And I'm saying that with air quotes for those listening. I have very close friends who have type 1, and there's nothing that infuriates them more than that statement, because especially with type 1 diabetes, it's not nothing you ate or didn't eat or caused the situation. So can we clear this myth up about sugar or lollies or treat foods causing diabetes?
Absolutely. This is such a common frustration for my clients with type 1 diabetes. And I often experience this, I guess, misconception working with families when they've got a child newly diagnosed with type 1. There's a lot of guilt around, we had quite a lot of chocolate over Easter, or, we've had lots of sugar. And I'm always very quick to reassure that type 1 diabetes, it is triggered by an immune response. There's a few theories around what that trigger is, and there's actually quite a lot of research going into that to try and understand what, those triggers might be, or why some people, develop these autoimmune conditions. But it is absolutely not a reflection on lifestyle or what you've been eating at all. Yeah.
Thank you for clearing that. I can hear the rounds of applause from anyone with type 1 listening to this podcast. So if somebody's perhaps, concerned that maybe they have diabetes, prediabetes, or insulin resistance of any type, what are some of the key symptoms or warning signs that we should be aware of, and maybe even what tests to consider looking at, or some key tests that their medical team would consider looking at if that was suspected?
That's a great question. And a lot of the signs and symptoms of prediabetes, for lots of people, there is actually no signs or symptoms. And this is a really important factor, and something that I often talk to my women who have had gestational diabetes and then planning future pregnancies, because for lots of people who either have prediabetes or even the early stages of type 2, they don't have any symptoms. So the only way to pick it up is to have, what we call some screening blood tests, or, some routine blood tests with the GP to make sure that we're picking that up as early as possible. Some people do report, if they are experiencing that insulin resistance, that they might have more fatigue and maybe some cravings and things like that, which might be associated if their insulin's not working as effectively. But it's really important to highlight that that's not the case for everyone. And there's also lots of other reasons why we might experience cravings or fatigue and things like that, as you're well aware of, Steph.
Yeah, absolutely. And what about, quote unquote, full-blown diabetes? You're out of the insulin resistance, out of prediabetes kind of stages, or in either, full-on type 1 or type 2 diabetes. Do they have common symptoms, and how does this present? Or are they also silent in the way that they present?
When someone's diagnosed with type 1 diabetes, there's usually more, because it's quite an acute onset of diabetes. So we often see things like excessive thirst, excessive urination, going to the toilet lots, excessive fatigue, and also excessive hunger as well, because the body's just not able to utilize the energy from food. So those are the signs of and things that we often see when someone's newly diagnosed with type 1. Yeah.
And is that the same for type 2?
It depends on what stage where type 2 is diagnosed. If we were experiencing those symptoms, it would be what we'd call, it would have progressed to the later stages of type 2, where the body wasn't producing any insulin anymore, or not producing as much insulin as the body's requiring. So usually it's picked up earlier than that, but that's not always the case.
Thanks for clarifying. And what are some of the tests or screenings that people could request if they're concerned that they may have insulin resistance or even diabetes? What tests should they be having a conversation about with their GP or endocrinologist or obstetrician, gynecologist, fertility specialist, whoever it is? Can you give us some pointers?
Yeah, so definitely the first person to check in with would be a GP, or if you were seeing a fertility specialist or another type of specialist who was ordering, bloods, it might be definitely worth asking, because they're generally, blood tests that can be easily added on to other routine bloods. So some of the blood tests that we'd be looking for is a fasting glucose level. So this is, just a bit of a marker of what our blood glucose levels are doing at rest when we're not eating. what we call a HbA1c, which is I guess, a bit of a marker of the average of our blood glucose levels over the last 3 months. So this is something that can also indicate if there's underlying diabetes. And then the other test is a oral glucose tolerance test. Now, anyone who's pregnant or had a pregnancy will be familiar with this one. It's the horrible glucose drink that women need to do in pregnancy as part of the routine screening for gestational diabetes. And this actually tests, I guess, that fasting glucose, but also our body's response to a glucose load. So for some people, when we talk about prediabetes, there's actually 2 different types of prediabetes. So there's impaired fasting glucose, so when we're not eating, but also impaired glucose tolerance. So that's after a glucose load, how our insulin production and blood glucose levels are responding after that load.
Yeah, thanks for clarifying those things. Yes, everybody knows about the 2-hour oral glucose tolerance test. I was just having a very long conversation with client yesterday who's had some very severe nausea in pregnancy, and she's like, how am I going to keep this drink down? Yes, you cannot puke the drink, otherwise the test is invalid. You got to keep it down.
Yeah,
absolutely. Yeah. But yes, the fasting glucose is a good one. And what about fasting insulin? Is that also a helpful marker?
Yeah, absolutely. So if we're concerned around insulin resistance, then that can be a marker. So if someone's having higher insulin levels, that can be a sign that there is underlying insulin resistance. And if we're concerned about particularly type 1 diabetes, there's a number of other tests that we can do where we look for the antibodies that are actually produced that, I guess, kill those insulin-producing cells as well.
Yeah. So how, now switching tones and thinking about fertility and diabetes, how does diabetes, either type or both, impact the ability to conceive for females? And we'll talk about males in a second, because we should not be leaving them out of the equation.
Absolutely.
When it comes to diabetes management and fertility. So let's start with females. What are the key kind of things that we need to consider in preparation for conception for women with diabetes?
Leading into pregnancy, it's really important that we're looking at that glycemic or blood glucose control, because we know that this has really important impact on egg health as well for women. Interestingly, in type 1 diabetes, I guess the impact of fertility and conception has actually changed over time. So historically, it was, we often saw that reduced insulin levels led to reduced hormones associated with fertility, like luteinizing hormones and follicle-stimulating hormones that are really important with regulating menstrual cycles and all those types of factors. But as technology has improved and what we call, I guess, intensification, or we're managing type 1 diabetes a lot more thoroughly, and we're using higher doses of insulin, we actually see more hyperinsulinemia, or I guess that insulin resistance, and even higher rates of polycystic ovarian syndrome in women with type 1 diabetes than the general population. So I think that's just quite interesting, showing that, as we've learned more about how to manage diabetes and we're reducing the risk of complications and things over time, that there is those other factors on fertility as well.
That's fascinating. I did not know about the higher rates of PCOS with type 1 diabetes. I was reading some articles very recently about the impact of insulin on ovulation, which is kind of quite well known, and is kind of one of the driving factors of why we have anovulatory infertility and PCOS, which is strongly correlated with insulin resistance. But as well, that insulin independently in the wrong settings can have an actual toxic effect on the development of placental cells, which is just mind-boggling. So I guess as well that hyperinsulinemia, which is that kind of elevated too much insulin or over insulinizing, if that's a word, is a consideration. And I guess fine-tuning your management so that you're getting the insulin you need to survive, the insulin you need to cover your meals if you've got type 1 or type 2 and require insulin, and 3, that you're in a good spot from a blood glucose control perspective before you then move into the phase of planning a pregnancy, because then the insulin requirements change again.
Absolutely.
Yeah.
And there's lots of technology and things around now too, so that can really help to optimize that. So it's a really important time if you are someone that has diabetes and you're planning pregnancy in the next, even 6 to 12 months. It's a really important time to be checking in with your diabetes team, finding an endocrinologist that you want to work with, that you have a good working relationship. It's just a really important time to be, as I like to say, sort of checking in with your diabetes and making sure that you are utilising all those technologies and medications and things that are available.
Yeah, absolutely. And so now switching gears and talking about men with diabetes, what is the impact of men with diabetes on their sperm health and their fertility?
Yeah, so we know that both type 1 and type 2 diabetes can impact sperm health and men's fertility. And there's a few different ways, I guess, in which diabetes can affect men's fertility. So a long-term complication of diabetes is erectile dysfunction, and also that hormonal regulation that we talk about for women as well. It also impacts men. So that can impact that libido and sex drive and things like that as well, which I think is really interesting. And then we also know that, that glycemic control, or if we're having high blood sugar levels, particularly for long periods of time, whether that's in type 1 or type 2 diabetes, it impacts sperm health in lots of different ways. So it impacts the volume of the sperm, the motility, can also impact the DNA and the morphology as well. And what we often find, I guess, when we have high blood sugar levels for extended periods of time is we get that high oxidative stress, or that pro-inflammatory response, which impacts sperm health too.
Yeah, absolutely. Well, thank you for covering those two key domains for us, Larissa. We're going to talk now a little bit about women who are concerned about gestational diabetes, whether they're earlier in their pregnancy or whether they are in the preconception phase. They maybe have a couple of the risk factors, which maybe you could talk us through, and they're feeling concerned that they're going to receive a diagnosis of GD and they want to take some steps to help reduce these risks of being diagnosed. What factors can they take control of, or what factors are outside of their control?
Yeah, so there's a range of different factors of why, I guess, some women develop gestational diabetes and why some women don't. And I'm going to start off just also by explaining a little bit about why gestational diabetes happens, because I think that will actually help a little bit to, I guess, understand why these different factors impact some women and others not. So pregnancy itself is actually a state of insulin resistance. So the growth hormones that our placentas produce induce what we call some insulin resistance, and this particularly increases in the second and into the third trimester. So all women in pregnancy need 2 to 3 times more insulin in the third trimester than when they're not pregnant. Now, the reasons why, I guess, some women might develop gestational diabetes, or they're not able to, I guess, produce enough insulin to counteract that resistance, are things like age. So we know particularly pregnancies over the age of 40 are more likely to have gestational diabetes. A family history of type 2 diabetes. So we spoke about earlier the different types of diabetes. When we say family history, we're talking about a parent or a sibling or a sister who's had GDM as well, is also a risk factor. And then some cultural backgrounds and ethnicities are also more likely to have gestational diabetes as well. So those are the things, I guess, that we can't control. Unfortunately, you can't change your family, although I think some of us maybe at times wish we could. And then in terms of, I guess, some of the factors and lifestyle things that we can be looking at, whether it's before pregnancy, leading into pregnancy, and in those early stages of pregnancy is making sure we're active as much as possible, because we know activity actually helps to counteract that insulin resistance. So, pregnancy is not a time to start running marathons, but we know even just making sure we're getting that sort of 30 minutes of walking, or whether it's some prenatal Pilates, things like that will actually have a really beneficial impact on insulin resistance. Looking at, the types of carbohydrates that we're eating, the types of fats that we're eating as well. So having more good fats, following more of a Mediterranean-style diet approach can actually help to counteract some of that resistance and reduce the risk of GDM as well.
Amazing. And so sometimes GDM is still diagnosed even when you're ticking all the boxes. So what happens in that scenario where maybe you've got a client who's feeling quite distressed about the diagnosis of gestational diabetes, and that they're going to have to watch their diet and watch their exercise and be really vigilant and have more appointments and checking blood sugar levels and all sorts of things. And it does create a lot of stress and additional, I guess, health burden in pregnancy, but it is important to manage because of the consequences of unmanaged gestational diabetes can have on both you and your baby. But, somebody who's done all the right, quote unquote, healthy things, and then they still end up with the diagnosis, like what would you say to that person that was in your clinic?
Yeah. This is a conversation I have a number of times a week when, often people or women come into me and they're quite disheartened when they get that diagnosis of gestational diabetes. And it's important to remember those factors that we don't have control over. So, if you're someone that has a few risk factors such as older age and a family history of diabetes, and, some of those things we can't change, and they will increase our risk of gestational diabetes. But I guess to reassure anyone who has had that diagnosis, women with gestational diabetes can go on and have a healthy pregnancy, healthy delivery, healthy baby. Gestational diabetes means some more monitoring in terms that we're monitoring blood sugar levels in pregnancy. We know lots about how we can keep those blood sugar levels within the ranges that we're aiming for, which will reduce the risk of any negative impacts for mum and baby as well. So there's lots of lifestyle things. For a lot of women, it's just a matter of looking at watching what they're eating and keeping active, and that's all they need to do to manage that gestational diabetes. If we do need to use medications, there's lots of medications that we can use that we know are very safe in pregnancy and work very well in pregnancies with gestational diabetes.
And what about how preconception versus pregnancy? Like, a lot of people in the first trimester struggle to eat as well as what they hoped they probably would have eaten in pregnancy due to the symptoms of nausea, sometimes constipation and fatigue, maybe not doing as much meal preparation as they usually would. And this is all normal and very common. And, I always say just get through and do what you can, make the best decisions you can with what you've got, but don't beat yourself up about it. I get a lot of anxiety from people that do fall in those higher risk categories, either due to age or family history or previous history of GD, and they're like, oh my God, I can't stop eating toast. Like, is this going to increase my risk? So does I guess pregnancy nutrition have more of a bearance on gestational diabetes risk or preconception, or a bit of both? Or we don't know?
A bit of both. This is an area there's research coming out in risk of GDM and lifestyle factors all the time. Like, it's something that's growing, every week there's different studies coming out. I think if it's something that you can focus on preconception, that's beneficial, because there's certainly some factors that we see preconception that can help reduce that risk. But, even in pregnancy, there's things we can still be doing. Often a lot of women really are quite anxious or have a lot of guilt around, in the first trimester they were just eating a lot of carbs because that's all they can stomach. It's really common in the first trimester for women to be, having more carbohydrates than when they're not pregnant. When we actually look at the research around risk of gestational diabetes, choosing better quality carbohydrates, whole grain carbs, lower GI types of carbohydrate foods can actually help to reduce the risk as well. So often when I'm working with women, I will look at, what are they craving? What are they tolerating, I guess, in terms of food? How can we be, I guess, optimizing the types of carbohydrates that they can have to be still reducing that risk as well?
Yeah, absolutely. Now, just to start wrapping us up, can you share with us maybe 3 nutrition or lifestyle tips for those who are looking to enhance the management of their pre-existing diabetes or even reduce their risk of gestational diabetes to enhance their chances of conception and having a healthy pregnancy, so people have some practical things that they can take away from today's very informative episode?
Absolutely. So starting, particularly for women who have pre-existing diabetes leading into pregnancy or conception, starting to think about food from a nutrition point of view and focusing on nutritious foods that they can be eating more of, so foods that are really good for pregnancy and fertility, like, lots of green leafy veggies, oily fish, nuts and seeds and things. I think often when people have had diabetes for a long period of time, food becomes about blood sugar levels and that's kind of their focus. So I think while that's important and you still want to be considering that, as we've talked about, I think starting to think about some of those other factors and nutrition overall is a really, I guess, a bit of a shift in mindset sometimes for people. And then I guess some practical tips following a Mediterranean style of eating, which I know you're a big fan of, Steph. So we know that, choosing those healthy types of fats, prioritising things like olive oils, nuts, seeds, oily fish, making sure that we're having fish and seafood a couple of times a week will help to counteract that insulin resistance as we sort of lead into pregnancy, and also has lots of good solid research behind it around long-term risks of diabetes and diabetes complications long-term anyway. And then the other one, which I sort of touched on earlier, is choosing lower GI, your more whole grain quality types of carbohydrate foods. We don't need to be afraid of carbohydrate foods when it comes to fertility and pregnancy. We actually know that having a high intake of good quality carbohydrates is really beneficial from a pregnancy and prenatal nutrition perspective. So definitely choosing good quality carbs and not being afraid of them would be my number one take-home tip from today for anyone at risk of diabetes or with diabetes.
No keto diets, please. Read the subtext.
Yeah, absolutely. Yeah.
It's not advised, so please don't do it just for the sacrifice of your BGLs. It's not ideal for your fertility or pregnancy outcomes, so we definitely don't endorse that.
Absolutely.
Do you have anything else to add to what we've discussed today, Larissa?
No, I think it's just a really important time and an exciting time for people with diabetes to be, checking in with that diabetes team. So that includes, an endocrinologist, your GP, a diabetes educator, a dietitian with an interest in this area, who also understands diabetes as well.
Yeah,
is definitely the take home for today.
And even an exercise physiologist, might I just add, because they have such great insights into how to design customized exercise programs for your chronic conditions and tailoring it to your injuries and medical history and your fitness level and all those kinds of things. So, yeah, definitely check in with them as well. They're a really great resource.
Absolutely.
So where can people find out more about you, Larissa, and follow you on all your socials? We'll make sure to pop them in the show note as well.
Yeah, so you can find me on Instagram at prenatal_dietitian. And my website is www.larissatelfer.com.au. And I also have a Facebook page, which is Larissa Telfer Dietitian.
Awesome. I will leave all of that down below. Thank you again for your time and expertise today, Larissa. Always a pleasure to chat with you and to catch up and pick your brains about diabetes and fertility. And I will see you all in the next episode. Well, I won't see you all, but we'll reconnect in the next episode, everyone. Don't forget to leave a rating and a review in Apple Podcasts, subscribe and share with a family member, friend, or a colleague, or on your socials, and tag me at _Dietologist, and we'll chat very soon.